The new ambition of care in both asthma and CRSwNP isn't just about symptom control, it's about achieving remission. Both conditions are underpinned by underlying type 2 inflammation, which gives rise to symptoms in both the lower and the upper airways. In recent years, there has been a seismic shift in the ambition of care for asthma and CRSwNP, and that is where Euphoria comes in. Broadcasting from London in the United Kingdom, this is Euphoria News. Hello and welcome to Euphoria News. I'm Dr. David Bull. Remission. It's the new buzzword in the management of both asthma and CRSwNP and deemed to be the gold standard of care. It is now felt that symptom control simply isn't good enough. In contrast to other medical conditions, achieving remission as the goal of therapeutic interventions has been neglected for decades, but that is now changing. Novel treatment options allowing personalised care, preventative strategies and multidisciplinarity of care have allowed the medical community to improve care for those suffering from severe asthma and severe CRSwNP. Euphoria has recently published a consensus statement on remission in both asthma as well as in CRSwNP, with the aim of allowing respiratory care physicians to speak the same language, whilst at the same time allowing patients to understand what is trying to be achieved in terms of care and clinical outcome. Remission is the new holy grail in care for patients suffering from asthma and CRSwNP. Well, to discuss this in more detail with me is Professor Yvonne Chan. She is otolaryngologist in chief based at St Michael's Hospital in Toronto. She is also Associate Professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Toronto in Canada. Professor, really good to talk to you today. Perhaps we could start just by outlining what exactly do we mean by remission when it comes to CRSwNP?
Great question, David. Remission is now increasingly considered an achievable goal in CRS with NP. We're talking about the sustained control of symptoms for patients and endoscopic appearance of very minimal inflammation, and also the possible, looking forward, any kind of biochemical remission or pathological remission on tissue biopsies.
Okay, so you talk about there about sustained controlled and endoscopic appearance, the biochemical changes and so on. I talked right at the beginning actually about this being the new gold standard. How achievable is remission if it is the new gold standard?
Well, we're looking for it to be the new gold standard, of course. In the past, we have always struggled with just establishing control for patients with CRS with NP. But with the new advent of therapies and the better understanding of these different disease endotypes in type 2 inflammation, I and, of course, a lot of my colleagues are starting to believe that remission can be achieved using a precision medicine approach for that individual patient. Okay, and understanding the type 2 pathways and the targets that we can actually treat. So these will include medical management, surgery, as well as biologics and long-term monitoring. So the goal is no longer symptom control. It is disease modification in the long term and improved quality of life.
And of course, that's a huge shift actually in terms of what you're trying to achieve clinically. In terms of trying to get to that stage, what do you see as the major obstacle to achieve remission in daily practice?
Well, we think that achieving remission is possible, but in daily practices, there are some major obstacles that I can think of. So CRS with polyps are definitely underdiagnosed and sometimes difficult for the primary care to assess because they require CT and nasal endoscopy and sometimes confused with upper respiratory tract infection and allergies. And patients also are not very compliant oftentimes with the consistent use of medical therapy because they feel better. Now, biologics are also very expensive. And unfortunately, sometimes patients are not eligible due to limitations of insurance coverage, or they can be restricted by prescribing criteria in different places. Canada, UK, North America, Asia, they all have different prescribing criteria, unfortunately. And also the lack of biomarkers in routine clinical practice at the moment make it really hard to tailor treatments for these patients. But hopefully, with the advent of multidisciplinary care, we will be able to combine our forces with allergists, respirologists, and otolaryngologists to help with these patients with other type 2 comorbidities, and so that they're not fragmented and we have coordinated plans for all of them.
I mean, there you talked about combining expertise. Underpinning all of this, of course, is education. So how do we then go about educating peers and also patients? Because that's obviously going to be crucial in this, moving and shifting from treating the symptoms to actually trying to achieve remission.
So I think that it's important to frame our goals of remission clearly and meaningfully to both the patients and our colleagues in terms of clinical success and how to engage the patients. So let's focus on our peers. So I think we have to shift the mindset from symptom control to possibly long-term disease modification leading to remission. That is something that we were never taught. And of course, it took me quite a few years, been in practice for a long time. And, for me to change from a control mindset, it is amazing to see the patients do really, really well on some of these newer therapies. And then also emphasize that remission is not about perfection. It is about a sustained control. It is about the reduced need for steroids and surgery and a better quality of life. The other thing is, with Euphoria, EPOS, we have reference guidelines that is now highlighting remission as a realistic and achievable goal, especially with biologic and personalized care. And then, of course, promoting early identification of these patients, as well as combining collaboration with the different subspecialties, so then we can tackle these comorbidities together that really block remission in each of these areas. So I think for me, that would be important for the peers. Now, let's shift to patients. Using simple language and sort of achieving these goals with patients together, I think is important. We need to talk to patients about our goal of not just making you feel better today. We want you to stay better for a long time to come. And explain that remission really means that you're going to have fewer symptoms, less need for steroids, less surgeries, and improved smell. These are very, very important to the patients. And then, of course, empower them and then giving them the right combination of treatment. So then the disease is no longer controlling you like it has in the past.
You mentioned Euphoria there and the role of Euphoria. What do you think that role is for Euphoria in terms of trying to achieve remission, in terms of education, the pocket guides, the algorithms, talking to physicians, clinicians, talking to patients?
Yeah, no, I think Euphoria is definitely plays a key role. Even in North America, we use a lot of the Euphoria guidelines. So I think the first thing that Euphoria does is they advocate for remission as a realistic goal. So Euphoria has been shifting this idea and adding them to the consensus. And so in the position papers and expert meetings, they highlight that remission is the new therapeutic ambition for these patients with CRS with NP and asthma. And then this is going to help shift by advocating for this as a realistic goal. And then, of course, Euphoria collaborates with global experts. So then we can define consensus definitions and criteria in a measurable and practical way. So then we can use it in daily practice. So, for CRS with NP, we're proposing criteria like, absence or minimal nasal symptoms, no need for steroids, and normal or near normal endoscopy. So it's important to have these definitions that we can use on a daily basis. And of course, Euphoria also published guidelines and algorithms and clinical pathways for clinicians. So then they can promote these treatable traits to allergists, respirologists, otolaryngologists, and general practitioner to recognize the aim for remission and how we can use type 2 and endotype and driven approaches to treat these patients. And then another thing that Euphoria does really well is promoting multidisciplinary collaboration. It bridges the gap between all the different specialties and advocating for a unified approach, which is really, really crucial. And then the last thing that Euphoria also does is patient empowerment and awareness. They engage in the patient education, emphasizing that remission is definitely achievable to these patients with patient-friendly materials, webinars, and public health campaigns to raise awareness. So I believe that Euphoria definitely plays a pivotal role in this arena.
Well, it's been such a pleasure to talk to you. Thank you very much indeed for your time. That's Professor Yvonne Chan.
Thank you very much, David.
Well, let's now address achieving remission in asthma. Joining me now is Professor Michael Wexler. He is Professor of Medicine at the National Jewish Health Hospital based in Denver in Colorado in the United States. He's also Director of NJH Cohen Family Asthma Institute in the Division of Pulmonary, Critical Care and Sleep Medicine. Really good to talk to you, Professor. Perhaps I could start by asking you a very similar question to the one I asked Professor Chan, which is what exactly do you define as remission, in this case when it's applied to asthma?
Yeah, thanks for having me. Remission is an evolving term. It's a relatively new term in asthma. And it's the concept that we can get people to have sustained control, have no exacerbations, no utilization of oral corticosteroids, and have some type of stability or no loss of lung function over the course of a year. And there's a difference between response and remission. You can have patients who will respond to a given therapy. So for instance, someone who goes from 4 exacerbations a year to 2 exacerbations a year, that person is a responder, but that person isn't in remission because they continue to have symptoms and or exacerbations. And so our goal is to identify patients and predictors of patients who can get into a state where their asthma is really not bothersome while on whatever therapy they happen to be on.
So I rather like that, responders versus those that go into remission. So where are we exactly in terms of the pulmonology field when it comes to aiming for remission, the gold standard, in patients with asthma?
Yeah, so we've come a long way in the last several years with the utilization of biologic therapies, targeted monoclonal antibodies that work quite well in our patients with severe asthma. We've been able to achieve a fair amount of patients who can achieve remission with these novel therapies, who can get themselves into a state where they're no longer having exacerbations, their asthma is in good control, they're no longer requiring oral corticosteroids, and their lung function is stable. We can now, with the currently available therapies with inhaled corticosteroids and long-acting bronchodilators, adding on a biologic, patients who were very symptomatic beforehand, we can get up to 40% of our patients into remission, which was unheard of, I would say, for patients with severe asthma just a few years ago.
And of course, that must be extraordinary for the patient in terms of the way they feel, their prognosis. In many ways, it is a game changer, isn't it, when you start talking about remission as opposed to just control of symptoms?
Yeah, it's been huge. Patients can now engage in activities that they otherwise wouldn't have been able to. They can not worry about an unexpected exacerbation. That was a major issue for patients. You know, patients who wanted to go to their nephew's wedding but their asthma got worse that prohibited them from traveling. We used to see this all the time. And now with targeted therapies, when we give the right drug to the right patient, we're able to mitigate those circumstances, prevent the exacerbations from happening.
Well, you mentioned there having the right drug getting that into the right patient. What about the right physician? So does the level of care, whether it's a primary care provider, a secondary care provider, or even a tertiary care provider, does that influence your figures? You mentioned 40% there. So how does that change dependent on who you see?
Yeah, I think for standard asthma that isn't quite so severe, I think seeing a general practitioner or an internist, family doctor, I think that's okay for most of those patients. And most of those patients can gain control with a standard inhaler therapy with an inhaled steroid and a long-acting beta agonist. However, for patients who have more severe disease, patients who are having 2 exacerbations a year or more, patients who continue to have symptoms, patients who have low lung function, or patients who have oral corticosteroid use, I think it's appropriate to send those patients and refer those patients to a specialist who can have greater insight into the underlying disease, who can do appropriate testing to find out what type of asthma the patient has. And then another important function of the specialist is to do an extensive workup to address the mitigating factors that can contribute to the worsening of asthma that aren't necessarily due to the asthma itself. For instance, when I see a patient with severe asthma, I take several steps, patients who are poorly controlled. First, I want to confirm the diagnosis of asthma, and it isn't always so straightforward. Some patients who are thought to have asthma may have something else. And then I want to evaluate, make sure that they are adherent to therapy. Are they taking their inhalers properly? And then, even before I check for biomarkers, I want to evaluate, are there other complicating comorbidities that can contribute to asthma that need to be controlled?
Now, for healthcare systems around the world, cost is always going to be an issue. What about the economic considerations when we start looking about remission in asthma?
Yeah, well, we know that we spend billions of dollars, billions of pounds a year taking care of patients with asthma, and about 80% of the costs of asthma are borne by the 20% of patients who are the most severe.
Well, it's been fantastic to talk to you. Thank you so much for your time. That's Professor Michael Wechsler.
Thank you so much.
Well, there you have it. Euphoria playing a very pivotal role in educating both physicians and patients about the shift in aspiration from managing symptoms to achieving remission. Many thanks to my guests, to Professor Yvonne Chan and Professor Michael Wechsler. Now, you can find more information about Euphoria and also register for the Euphoria educational events on the euphoria.eu website, where you can also sign up to receive the latest news via email. We're also on social media on YouTube, X, LinkedIn, Spotify, Instagram, and Facebook. Please do follow us. Until next time, goodbye.